Okay, so let me get the section I want to talk about. Will stay the same throughout the entire course and through Pharm. We'll talk about this as we get to them. Typically, these are the things you're going to be learning about these drugs as we go through and talk about them individually, right? So we're going to know things like mechanism of action. When I say mechanism of action, what do I mean? What does the drug do, right? What does it do to the body? Those pharmacodynamics or principles there, right? We're going to look at things like indications. What do we use these drugs for? You know, I say things like off-label use. What does that mean?
Not primarily what it's used for, but the side effect can have a...
That could be one, yeah, that could be one thing for it. But typically what you'll see is when the drug company goes to the FDA and says, hey, we want to market this drug for this indication, right? So for instance, if I had, go back to the drug sildenafil, right? We use that for erectile dysfunction, right? So if I go to the FDA and say, hey, I want to use this for erectile dysfunction, they say, okay, here's the studies, you know, everything looks good, let's go ahead and market it for that. However, we find that, hey, it also works for pulmonary hypertension. That's an off-label use. They may not have an actual indication for it at that time, but it still can be used. That's not illegal. It's something that happens all the time. But we'll talk about label uses, off-label uses, things like that. We'll talk about contraindications. What is that? When to not use the drug, right? So just as important as to know when to use the drug, you want to know when not to use the drug, who not to use the drug in. Very important things because you can really cause some serious harm if you don't heed those. We'll talk about side effects, adverse reactions. We'll talk about monitoring, drug interaction, all these different things we're going to cover as we get to specific things. You'll find that you know, you're not going to know every single detail about every single drug when you leave this class. I'm going to cover the big things you want to know, and I try to make this so that you're not going to be a little pharmacist when you leave here. You're going to be PAs, right? I want to give you things that are going to be actionable knowledge that you can actually use when you're out there prescribing things for patients. As such, you're not going to get, you know, I'm not going to go through Goodman and Gilman's page by page and make you know every single detail. That's just unreasonable, right? But if I harp on things, if I talk about things like, hey, this is a really big drug interaction, that's the thing you probably want to know, because again, not only is it good for clinical practice, it's also good for the test, right? And so again, if I sit there and harp on something for 10 minutes, like it's probably going to be something that shows up on the test if I had to guess, right? Some people do really benefit from flashcards. There's not one particular set of flashcards that I would recommend over another. Any of them can do the job. However, some of them may have more or less information than what you need to excel in this class. So what I would recommend is that they're all on paper, basically, like make some changes to them, right? So again, if you have a flashcard that's talking about I don't know, something like amoxicillin, and they forget to cover something that I really harped on a lot in class, I add that to the card, right? Or if there's something that, you know, seems like it's going into too much detail that I didn't really talk about much, cut it out of that card. You don't need to spend that mental real estate to try to memorize all those details when it might not really even come up, okay? Because again, it's like, you know, nausea and vomiting with drugs. Like, which drugs cause nausea and vomiting? All of them, right? Every single drug has reported nausea and vomiting, because anytime you're having a clinical trial and someone takes a drug and they have a side effect, it has to get reported, right? So again, nausea and vomiting probably gets reported. Now, does it have to be due to that drug? Probably not, right? In a lot of cases, maybe do it, maybe not. So you're going to find that trying to memorize every single side effect is just not really worth your time. But the big ones we're going to hit on are going to be big things I want you to kind of focus on, and we'll talk about them more in detail here, right? Also, things like, you know, patient education, I want to really hit on this because, again, you cannot guarantee that when you write a prescription for a patient that when they go to the pharmacist, they're going to have all the time in the world to sit down with them and go over all the side effects and how they should take it. Those guys get busy too, right? And so we want to make sure that, at least as far as like the Swiss cheese model goes, we want to make sure that you're going to be as holeless as possible and making sure that you're educating those patients and then make sure they know everything they really need to by the time they leave you. So even if the pharmacist doesn't give them the time of day, you can still, which that'd be a bad pharmacist, but it does happen. They can make sure they have all the knowledge they need to succeed, right? This is not the end all of all pharmacology. I would recommend that, you know, I wouldn't, you know, try to say that you're going to know every single thing out there, as I've already mentioned, but use your references, right? Always make sure you're looking up things. If you're not sure, if it's something you've never done before, make sure you look up stuff. So you can look at the guidelines, you can look at your textbooks, online references like Lexicomp. I use that all the time. In fact, for your prescription assignments, if you use Lexicomp, you really can't go wrong as far as the knowledge coming from that. Also, when you're out there actually working, talk to your friendly pharmacist. We respond very well to gifts, not only monetary, but sometimes food also works very well for us. But like, just go and just pick their brains on stuff, right? So especially on rotations when you're there to learn, like just go, hey, you know, I saw my provider or, you know, saw my preceptor do this. You know, what do you think about that? You know, try to get those. It's always good to get, you know, different opinions on things and different perspectives. So one of the things you'll find is that you know, there's a lot of art and science when it comes to medicine. Like we would like it all to be science and all to say this is the right answer, this is the wrong answer, but guess what? It's not going to be the case, right? There's a million different ways to skin a cat, so to speak. And so that's especially important when you're looking at like CMS courses and versus things like, your pharm courses, right? So if Professor Q says something like, hey, this is how you should treat this disease state, and I come in and I say something that may be a little different or maybe conflicting, that's not a case to go back to the professors and be like, well, this person was wrong and this person was right. That's not the case, right? You want to go and try to ask the question, why? Why do you think this is the right answer versus why do you think this is the right answer, okay? That way you can get those differences in opinions and try to form your own opinion when you actually get out there and make decisions for your patients, right? So again, there's not always going to be one right answer. You're going to get frustrated by that, and I guarantee you that's going to happen, but it's just one of the things you're going to learn to deal with as a medical provider, right? And then if something doesn't look right, always ask questions. You never want to be able to never give a drug to a patient and then afterwards be like, oh, I actually wasn't really sure about that. I'm not really sure if that patient's going to do well with that, right? That's not the thing you want to keep you up at night when you leave your shift and go home. You want to ask a question beforehand to make sure you do things right. I get calls from nurses all the time like, I gave the drug, but I really wasn't sure about this one thing about it. And I was like, well, why'd you give the drug? Well, it was on my MAR and I had to give it in the time, blah, blah, blah. And I was like, well, ask a question beforehand. Always take that time because, again, can you take drugs out of the patient once you give them? Typically, no, right? It's a very difficult thing to do, so we don't want to have to do that. Enough rambling. Actually, I'm just starting the rambling, but we're going to get into talking about infectious disease. So the way that I structured this class, and we try to make sure that CMS matches up with pharm as best as possible, right? So we're going to have a little bit of times where that's not going to be always feasible, which is unfortunate, but it is the way it is. But for instance, when we get done with this, we're going to go into ENT, and guess what? You're covering ENT right now. I just saw you have some evidence of that. And so we try to line up things so that way you have some, at least, we're talking about antihistamines for treatment of ENT conditions. Like at least we'll cover antihistamines around the same time, so that way you can get those conflicting sort of perspectives and try to mash them together and say, okay, well, what do I know about this disease state? What do I know about this treatment, etc. The thing I do like to start out with first is going to be infectious disease, and primarily this is where we're going to talk about our bugs and drugs, okay? So why do you think I want to cover this at the very first thing as far as pharm goes? Because where do infections occur? Everywhere, right? So if you know the baseline drugs that are going to be able to treat these different infections, you're going to be able to apply that through every single disease that you run into. Because guess what? ENT, a lot of infectious disease. Guess what? Pulm, a lot of infectious disease. Guess what? Derm, a lot of infectious disease. So by getting this baseline down, you can apply this elsewhere, okay? So you're going to get hit with a lot of drugs all at once. That's okay. We want to focus on big classifications. You want to focus on things like, how can I group these drugs together? How can I find their similarities? And then once you know that very well, go in and drill down to what are the differences between them, right? So we talk about things like penicillins, like what differentiates penicillin versus amoxicillin versus piperacillin. We're going to look at those kind of differences there, right? Focus on things that are similar, know that first, and then look for those differences. That'll help you in trying to digest all these different drug names that are in here, okay? And again, it's okay if you can't pronounce something correctly, just if you have a question on how to pronounce something, that's totally fine. But it's good to get that stuff out of the way now, so that way you don't like go on rotations and you're like, I'd like to give the patient 1 liter of normazoline, and yes, I make that joke, but I don't want you to actually think that's how you say normal saline. Like, that would be very embarrassing if you went out there and said that. They say, who taught you pharm? And then you'd be like, Dr. Wood. Strikes again. Anyway, so let's go over a little bit of microbiology review. So have you started micro yet? You will soon. I'm not sure when you cover the bugs there, but this is a very kind of cursory overview. Again, most of you had microbiology before you came here, correct? I assume this is going to be very cursory, but it's important to know kind of the main differences amongst certain bugs, especially to know what sort of organ systems are going to be affected by certain bugs. We'll talk about some of the rationale behind that. You got to know the bugs in order to understand what drugs to use for those patients, right? So talking about gram stains, what's a gram stain? Yeah, it's a dye. Basically, we're going to take a culture of some bacteria, we're going to apply a dye to it, and based on whether or not the bacteria takes up the dye or whether it does not take up the dye is going to tell us whether it's gram positive or gram negative. This is the basis for, and when we talk about coverage of antibiotics, we talk about what bugs that an antibiotic will cover. This is one of the first delineations you're going to make. Does this cover gram positive? Does it cover gram negative? That's one of the first questions you're going to ask yourself about a drug, right? And again, it goes back to basically this peptidoglycan wall that is going to be surrounding the bacteria. Okay, the walls of bacteria are super, super important because one of the ways that we can kill bacteria is by disrupting this wall. We're going to find a ton of drugs that are actually going to do this for us. But when you find gram-positive, they end up taking up the stain. So these are considered gram-positive because they have retain that stain, and they're going to show up as dark purple, right? So again, how often do I, as a practitioner, ever look at the actual bacteria growing? Not ever, right? But I do get reports out that say, hey, you have gram-positive diplococci, or you have gram-negative rods that are growing. These are sort of the things you're going to get a feel for. So even though if you're not actually looking at the bugs themselves, the report you can at least interpret to make some sort of delineation for what type of bacteria am I dealing with. Gram-negative typically show up a little bit more pink. They don't take up that stain because they actually have this lipopolysaccharide coating that kind of prevents them from uptaking as much of that stain. We'll also talk about another kind of broad categorization of bacteria called atypical pathogens. Those typically are going to be ones that don't really take up the stain whatsoever. They don't have a particular color that gets associated with them, but we'll talk about those more specifically in a moment. So knowing common gram-positive cocci that you're going to run into, and again, I'm not going to have you, I'm not going to ask you specifically on a test, Enterococcus faecalis is this type of bacteria. I have gram-negative rod, I don't really care if you know that so much, but I want you to at least start to make these associations. You're going to get a lot more of this in micro, but we're going to focus on things that are the common ones you're going to run into, where they reside most commonly on the person, or what type of infections are most likely to cause. But one of the big ones we run into first off is going to be Staphylococcus aureus. Where does Staphylococcus aureus live on a person? Skin all over, and you guys are all covered in right now. Isn't that creepy? Yes, we have all kinds of bacteria over us, but Staph aureus is going to be one of the big ones. You're going to find that the two big delineations for Staph aureus is going to be MRSA and then MSSA. Does anyone know what that stands for? Methicillin sensitive or methicillin resistant Staph aureus. Well, what's methicillin? If you had to guess. It's an antibiotic, right? So again, we're going to talk about resistance. We're going to talk about sensitivities. When something is sensitive to an antibiotic, that means that antibiotic can come along and kill it. Okay, that's good. We want things to be sensitive for the most part. When you have something that's resistant, that means that I can give as much methicillin as I want. I can basically bathe that MRSA in methicillin. Guess what? Nothing's going to happen. That MRSA is going to laugh at it. It's going to continue to grow, continue causing infections, right? So this is one of our big delineations. You talk about gram-positive bugs. Oftentimes, Staph aureus is one of the big ones you're thinking about, and then you have to delineate MSSA versus MRSA, okay? So we also have things like Staph epidermidis is a very common skin contaminant. Very frequently when you have things like blood cultures being drawn that are going through the skin, oftentimes you'll find Staph epi is going to be one of the big things that will contaminate a lot of that. Doesn't always mean you have a bloodstream infection with Staph epi. In fact, that's quite rare as opposed to finding it as a contaminant, but certainly one you're going to find on the skin, which makes sense. It has epidermis right there in the name, right? Other things like strep pneumo, anyone know where we find that? Perhaps you covered it in CMS, possibly, in ENT. Again, we haven't gotten there yet. Strep pneumo is going to be really, really prominent for a lot of ENT sort of infections, right? So you think about things like acute media, think about things like pneumonias, pharyngitis. Like you're going to find a lot of strep pneumo is going to be involved with that. So again, I'll show you some tables later that kind of break down different organ systems and what kind of bugs are most commonly going to be there. But again, think a lot of upper respiratory tract infections. Think a lot of strep pneumo is going to be there. Anything pneumo, think kind of the airway. That kind of makes some sense there. And then we have things like Enterococcus faecalis and faecium. Where do you think you'd find Enterococcus? Yeah, you find that a lot in the GI tract. So oftentimes we can have things like Enterococcus. And again, what's very close, especially in female patients, to the anus? The urinary, the vagina and the urinary tract, right? So again, you see a lot of translocation of, say, gut bacteria that can enter into the urinary tract, and so sometimes you can find that they will have, these kind of gut bugs are showing up in the urinary tract. You think, why is that? And you think, okay, well, anatomically, it's very close there, so you find a lot of that in the gut. So when I say anaerobes, what does this mean? Means it does not need oxygen in order to grow. And so typically when I'm talking about things like gram-positive, gram-negative, just assume I say I'm talking about aerobic bacteria unless I specifically say anaerobes, okay? Because anaerobes are going to be kind of another classification you want to think about when you're talking about coverage of your antibiotics. But some of the gram-positive anaerobes you're going to run into are things that grow in areas without oxygen. Like where would you find sort of oxygen poor sort of environments for these bugs to grow? GI tract's a big one, right? So GI tract, you're going to find a lot of that. Also, the mouth tends to be an area where you see a lot of anaerobes tend to grow. So things like Peptostreptococcus, Peptococcus. If you were to have, say, for instance, a bite that were to come into your ER, someone got bit by a person or an animal or something like that, these are kind of bugs you have to think about, right? So you're already starting to think, okay, well, I have a bite, so if someone bites through the skin, you're already thinking, okay, well, I know I have a lot of gram-positive aerobes that grow on the skin, so I have to think about that possibly causing infection. Now I got to think about stuff that's in the mouth causing infection as well. So now I got to think about gram-positive anaerobes. So these are the thought processes you're going to be kind of going through when you're saying, okay, well, I need to treat this patient's bite. How's that going to happen, right? Of course, you want to ask, like, well, what did you do to get bit in the first place? But that's a whole other question. I had an alligator bite that came in probably early in the summertime. Small girl got bit, and they're like, what do we cover for? I'm like, I don't know what the heck grows in a freaking alligator's mouth. Like, I can guess, but so we had to look it up, and you actually find there's some resources out there that tells you, okay, this is what typically grows in alligator mouth. Here's what you should cover for. So anyway, other big things to think about, things like Clostridium. So Clostridium tends to be anaerobic bacteria here. So one of the big ones you're going into, a big consequence of antibiotic therapy, is going to be things like Clostridium difficile. Anyone know what this causes? C. diff, right? So when you see C. diff, it's Clostridium difficile. And in fact, when I bought my Subaru, and I originally got that, I don't know if I told you the story, when I bought my Subaru, there's a tiny button on there for the center differential. You can actually change the settings on it. And my wife got it in the car, and of course, center differential also gets abbreviated to C. diff. So my wife got in the car, and she's like, your car already has C. diff. We just bought this thing. You need to get rid of it. Not that C. diff. Smells a lot better than that C. diff. But anyway, big problem, especially with patients receiving antibiotics. And why do you think this occurred? Why do you think this bug tends to predominate when you have antibiotics being used in a patient? Yeah, so gut flora is a huge thing. So we have a normal, natural gut flora that can coexist with us on a day-to-day basis. It does not cause infection, but anytime I have antibiotics, and it'd be nice if I could specifically just treat one particular type of bacteria treating infection, but that's not the case. Usually you're going to have some collateral damage, and a lot of times you have the gut flora being disrupted, and that's going to cause things like these kind of opportunistic infections to occur. C. diff is a huge one, especially in the hospital. Patient develops C. diff, that's a big problem because, again, oftentimes we're the ones that gave that patient C. diff, and does insurance want to cover that? Nope. Not at all, right? So again, this is one of the big things where we're trying to prevent this from occurring in the first place, but it definitely does occur. Now, a even larger sort of group of bacteria you're going to be dealing with very frequently are going to be the gram-negative bacilli. These can be broken down to several categories here. Things like the Enterobacteriaceae. These are going to be things including like Citrobacter, Anaerobacter. A lot of these are going to be gram-negative bugs, especially found in the GI tract. A lot of times, again, I mentioned that anatomical, kind of proximity between the GI tract and things like the urinary tract. Oftentimes, you find a lot of translocation of these bugs and causing a lot of infection. So, like an E. coli, UTI is actually quite frequently seen. And things like Proteus, things like Serratia can all cause things like these UTIs to occur here. So those are big places you're going to find that. Things like anaerobic gram-negatives, Bacteroides fragilis is going to be a big one we'll talk about with some regularity there. Some of the other ones I would like to talk about, though, are going to be things like, and this is actually one of the big buzzwords. So when I talk about MRSA, whenever that comes up, that's probably something you should make a big note about. The other big bacteria that I'm going to make you kind of think about a lot of is Pseudomonas aeruginosa. Okay, anyone know where you find Pseudomonas?
Otitis externa.
So that's an otitis externa. Any particular place? Maybe you guys were in one of these during the break. You had some time off. Maybe you're trying to relax a little bit. Head out to maybe like the jacuzzi, right? Yeah. So like heated water tends to be a nice cesspit of Pseudomonas. So it's one thing we find there quite frequently. But contact lenses tend to have Pseudomonas as well. See infections with that. But Pseudomonas is a big one because Pseudomonas, when this causes an infection in a person, it can be devastating. This can be oftentimes when you see these patients in the ICU who are on ventilators. This can be the thing that kills them, basically, right? They have a thing like a Pseudomonas sepsis or like an MRSA sepsis. These are the big time bugs we really want to be concerned about. So when I talk about Pseudomonas coverage, talk about MRSA coverage, you want to perk your ears up. You want to think about that and make sure you note that down, okay? Other ones you can come up with, sometimes you'll have specific bugs that come up in certain like circumstances. So for instance, something like Stenotrophomonas multifida. Sometimes patients with specific disease states will develop these infections. So for instance, normal healthy individual does not get infected with Stenotrophomonas very frequently. However, if you have something like an impaired respiratory tract, like you have a CF patient, right? We talked about CF kind of briefly, how they get these very thick, tenacious sort of secretions. They have a hard time getting rid of a lot of those bacteria there because normally the lung should be pretty sterile, right? They don't have that ability, so they end up developing bacterial infections with things that we don't normally think about for healthy individuals. Stenotrophomonas can be one of those, right? Another big one we worry about for especially resistant, very difficult to treat infections can be things like Acinetobacter. Be a really bad one. And then some other kind of random ones we'll talk about as well, things like H. influenza. We'll talk about that very frequently for ENT concerns and upper respiratory tract infections, Marxella catarrhalis, and then Neisseria gonorrhea, which obviously causes gonorrhea, and then Neisseria meningitis, yes. I actually had one, we saw one really severe case probably about a year ago of Neisseria meningitis, and it was very severe. The patient basically came in, was talking. Well, and who knows how long he'd been infected before he got to us, but basically was talking, was alert and oriented, and then within 8 hours or so, the patient was dead from that infection, right? So this can be very, very nasty from a meningitis standpoint. But again, you're going to learn as you get kind of more familiarity with these bugs, kind of where are you most likely to find them as far as causing infections, right? Some other atypical pathogens we'll talk about with some regularity are going to be things like chlamydia. We'll talk about Legionella pneumonia. Anyone know what Legionella causes? It causes pneumonia. Thank you. But what type of pneumonia? Anyone ever heard of Legionnaire's disease? Yep. That actually comes from Legionella, right? So actually, if you ever hear, you have a case vignette of like an infection, like a respiratory illness that developed after, people had like maybe a malfunctioning AC unit or something like that. Oftentimes you think Legionnaire's disease and Legionella. And then another big one is Mycoplasma pneumonia. We'll run across that one quite frequently. Okay. You don't need to memorize this list necessarily, but I'm trying to get you at least familiar with a lot of the common ones we're going to run into, because you're going to see this infectious disease pop up every single section we talk about, basically. So looking at it by site of infection, you can start to make some of these linkages here. You can start to make these associations between, like, where do you normally find these bugs and what kind of infections are they going to cause? So when I say skin and soft tissue infections, we already kind of know what are we thinking about. Staph, also think about, Staph aureus, but also Staph epi. You're thinking about gram-positive bugs, right? Now, is that always going to be the case? Not always. And sometimes you can have things like trauma, where maybe you're having introduction of sort of different types of bacteria into a wound that you may not normally think about, right? So again, if you have someone who's on a motorcycle, they crash and they're being dragged along the asphalt for several feet, maybe you're introducing all kinds of bacteria that normally would not be causing a skin infection. These are things you have to think about, right? Now, looking at bone and joint, you also start to see that, again, this is usually sort of an ongoing process with skin stuff. So you see a lot of gram-positives here, but then sometimes you can even see things like gram-negative rods, right? So you imagine someone who has, say, for instance, like a really nasty decubitus ulcer that has been developing, kind of festering over time, that can eventually get down to the bone, and then you're starting to think about things like gut bugs getting in there, and that's where you can see those gram-negative rods start to develop, right? And again, don't memorize this list necessarily, but we're going to start to make these associations, and this is where I want you to at least start to think about it right now, okay? Meningitis, you're going to find that there are certain things like strep pneumo, Neisseria, H flu are going to be kind of the common ones. Now, sometimes you can find that patients with different age ranges can actually be more or less likely to develop an infection with a particular bug. So for instance, kids that are less than, say, 6 months or so, Listeria tends to be a much more common bug you might run into, right? Versus as they get older, they become more resilient against it and may not see that. Now, why do you think I make this association between a particular type of infection and the bugs that are going to be caught? Why are we talking about this in a pharm class? Right, it tells us what medications we need to use. So if you already think, okay, I have someone with cellulitis, you already know, okay, well, I think these are the most common bugs to cause this infection. I know what I need to cover it with as far as the drugs go, okay? This is the bugs and drugs portion of it, right, where we're saying, okay, well, I know that if I have a patient with skin soft tissue infection, I'm thinking Staph aureus, I'm thinking Staph epi. I know I'm thinking a lot of gram-positive bugs. I want something that's going to cover gram-positives, okay? And once we get to the drugs, we'll talk about what those coverages are going to be. We'll talk about, kind of broad strokes, how these drugs are going to be covering these bacteria, okay? Things like, the abdomen, you're going to see a lot of gram-negative bugs. That makes sense. A lot of gram-negatives live in the abdomen, right? In the GI tract. You also see things like, anaerobic bacteria can also be a concern here, right? So when I have patients who are coming in for appendicitis and they're going to go for a laparoscopic appendectomy, we have to cover for not only gram-negative bugs that might be, released from the GI tract into the surrounding abdominal cavity. You also have to think about anaerobic bugs as well, right? So we have to cover with 2 different types of drugs in some instances. Urinary tract, we're thinking a lot of gram-negatives. The mouth, we're thinking a lot of anaerobes. So again, you're going to find that the way I treat a urinary tract infection may be very different than how I would treat, say, for instance, an infection from a bite wound, right? Because of the fact that the bacteria may be likely to cause infection is going to be different, right? Now, when I treat a patient with an infection, do I 100% know exactly what bacteria is causing that infection? Very frequently you don't, right? Because again, this is why we're going off of probabilities. We're going off of what we think is most likely to be common based on, the reported literature, saying, okay, well, we think, most of the time cellulitis, abscesses, going to be some MRSA in there. Let's cover for that, right? We know that based on probabilities, you're most likely to get that. Because again, nothing in medicine is 100%, unless you were to actually, how could we tell specifically what bacteria was causing that infection? Culture it out, but what do cultures take? Take time, right? And I need to treat that patient's infection right now. So that's what we're going to talk about in empirical minutes here. You're going to see things like upper respiratory tract infections are going to cause by things like strep pneumo, H flu. Sometimes it's not just gram-positive. Sometimes it's a mix of things like H flu, strep pneumo can be kind of all mixed together to potentially cause one of these infections here. And if we don't know what's causing the infection, we may be choosing the wrong antibiotic potentially, right? Now, when you look at things like lower respiratory tracts, you think about things like pneumonias. What's the difference between like community and what do I mean when I say nosocomial? Yes, that they got from healthcare treatment, basically, right? So if they live in a nursing home, right? If they are in the ICU for a month, these are things that they're picking up from us, from the healthcare field, basically. And so you're going to notice that typically nosocomial infections tend to be much more difficult to treat. You're dealing with a lot nastier sort of bugs. You're dealing with much more resistant sorts of bugs, okay? And I always say the worst place to get healthy is in a hospital because the whole place is covered in bacteria, right? As much as you try to do things like having good infection control and whatnot, there's always a possibility, right? So you see things like MRSA, you see things like Pseudomonas that can be causing these infections here. So just know that, you know, sometimes depending on the age of the patient, depending on comorbid conditions, depending on, you know, where do they live at, where have they been exposed to, can oftentimes change what bacteria might be causing an infection. So, anyone ever heard of an antibiogram? These can be very, very useful when you're working in the community or working in a hospital sort of setting. This is an example of an antibiogram that was done. It's kind of an old one from 2007, but the point still stands. So basically what I would have here on this column is going to be gram-negative bugs, I have gram-positive bugs, and then I have a number of isolates. And when I say isolates, what does that mean? Yeah, single cultures that I got from a patient essentially, right? So again, for instance, when this one with E. coli, I had 1,002 isolates versus something like, let's say Pseudomonas aeruginosa 74. What does that tell you about how often these infections pop up? E. coli tends to be a lot more common. I had 1,000 isolates versus just 74 for Pseudomonas. So it tells me E. coli is probably a lot more common out there in the patients I'm treating, right? And then you'll notice here, you have a list of drugs going along in this row. And so this number is basically telling you what percentage of those isolates were susceptible to that antibiotic, okay? So ideally, what number would we like to see in these boxes here when we select our antibiotic? I'd like to see 100%, right? I would like to have 100% certainty that when I treat this sort of bacteria with this drug, that's going to be effective, right? So for instance, if I'm trying to treat E. coli, you know, I might want to choose something like, say, ceftazidime, or maybe something like a ceftriaxone, 96%, that's pretty good. Or maybe I can even use something like imipenem, 100%. That's really good. Versus I would not want to use something like, say, ampicillin. Ampicillin is a 65% susceptibility to E. coli. Do you want to treat your patient and say, hey, listen, I'm going to give you this drug. It's going to cause some side effects, and I only have a 65% chance it's actually going to work. Patients aren't going to like that, right? They're like, I want a 100% chance, right? You're the healthcare provider here, not me. And so we use these very frequently. And again, do these things, do you think these stay static?
No.
They change all the time, right? Because these bugs do not like to be killed off by bacteria or by these antibiotics. And so guess what? They're going to evolve. They're going to change. They're going to try to get more resistant. And so you can see these things will shift over time. Yes, sir.
Just so I understand, an antibiogram is just culture obtained from one patient, and it just shows.
This is actually from a lot of patients, right? So this would be this is done by an institution. So for instance, in this case, it was the St. Anne's Hospital. They took all their lab, basically took all this data they had from all these patients with their cultures being done just in the routine normal care of patients, you know, either from the ER, the ICU, wherever they happen to be. And they bring all this data together to say, okay, well, this is what our environment looks like. This is what our community sort of looks like. So for instance, if I'm going from, say, from Maine, do you think this looks the same as it would in, say, Orlando? It's very different, right? We have different bugs that grow here. There's a different environment, different resistance patterns. You know, if you went over to California, you may see something even very different from that, right? So, you know, it's really interesting. I remember going to one conference and they had an ID specialist that was there, and he was inviting people to bring their institution's antibiograms to that presentation, so he could actually evaluate them and go like, oh, this is actually crazy because you have this going on, blah blah blah. And like, you know, someone came from like, up in the mountains somewhere, like in the Rocky Mountains, like very secluded area, and like everything was susceptible. We're just like, oh, that's awesome. Like that would be great if everything was susceptible. But most of the time we don't live in that sort of environment, right? So these are very good to go back and just be familiar with. So that way you can say, well, if I think it's MRSA, I'm more likely to get more benefit from using Bacterium versus using something like clindamycin. And these are things we'll talk about.
How frequently, like, do institutions do this? Is it common, like, like in Orlando, like for a hospital, like do they do this?
Yeah, every institution does it. You know, actually, a good use case for this would be when we first opened up Nemours, right? So, and again, you'll find that like kids have different sort of bacterial spectrums than adults might, right? So, for instance, when we first started up, guess how many isolates we had available to us? 0. We're a brand new hospital, right? We didn't have anyone cultured yet. So we still need some information. So what I actually end up doing, you find a lot of this is that we we go to our buddies and, hey, you still work at APH, right? Yeah. Can you hook me up with that antibiogram? Can you send that over to me? And then by sharing that information, we at least have an idea, right? So downtown Orlando might be a little different than say Lake Nona, but guess what? It's probably close enough, right, for government work, so to speak, right? So from that regard, we were able to use that information until we had enough isolates of our own to say, like, hey, this is a pretty representative sample. Sometimes it takes a couple of years, depending on your patient load and things like that, how many cultures you do. But once you have this, then you update it, usually yearly or every couple of years or so to make sure that it's going to be clinically relevant for the patients that you're seeing there. So yeah, Florida Hospital will have one, ORMC will have one, any hospital is going to have their own. And so sometimes you may find, especially like these big groups, they may have, say, a whole system-wide one, right? Or they may have individual hospital ones, right? So like Dr. Phillips might be a little bit different than say, ORMC downtown, et cetera. Okay, makes sense? So these are good things. If you're on rotations, just ask it to look at a copy of this. So you should be able to find one. Actually, most of your providers may not even know that it exists, but you can tell them, hey, you have an antibiogram. You may just not know about it. It can be very useful in helping you decide which antibiotics to use and for one type of infection versus another, right? Okay, so how do we know whether the bacteria is actually susceptible to the antibiotic? So we do these tests here, right? So for instance, in this case here, we will culture out the bacteria. And what do you think these little dots are? These little white dots. These are different antibiotics, right? So again, based on, and what do you think, how can you discern between a good antibiotic and a bad antibiotic? Yeah, so the bigger the circle, we call this the zone of inhibition, right? Because if you had to guess, looking at it right here, this dot here, where do you think the concentration of drug is highest? Close to the disc, right? So then as you disperse out, right, just due to passive diffusion, you're going to find the concentrations of the drug will get lower and lower and lower and lower. There's always going to be a certain point where the bacteria are going to be able to grow in that lowered concentration of the antibiotic, right? So we call that a zone of inhibition. Obviously, the bigger the zone, which means that you need a lower concentration in order to inhibit that bacteria from growing, the better the drug is going to be able to have the ability to kill that bacteria, basically, right? So in this case, this one actually be pretty crummy, I would imagine, because it has really almost no perceptible zone of inhibition versus something like this is a nice clear demarcation here. And again, note it's almost kind of like an on-off sort of thing. Once it gets down to a certain threshold, that certain concentration, bacteria just start to grow, right? And so again, we're going to call this the minimum inhibitory concentration. Okay, this is the lowest concentration that we need to achieve with our antibiotic in order to make sure that we can kill off that bacteria and make sure it is going to be prevented from continuing to grow. Okay, because again, when we give someone an antibiotic, is that the only thing that's killing off those bacteria? No, the host immune system needs to be able to help out as well, right? We need to, basically we're using the antibiotics to work in conjunction with our own host immune system in order to clear off those bacteria. So frequently, antibiotics are just trying to inhibit the bacteria from growing. So that way our own white cells and whatnot can come in and then knock out the rest of it, okay? So again, they need to work in tandem in order to make sure that that happens. So very frequently, the antibiotics are just going to be able to inhibit that growth. In some cases, we'll find they're actually directly killing the bacteria, but we'll look at those differences in a few minutes. Other ways you can do it, here's kind of a different way to do the same thing, where basically you could look at the zone of inhibition. Obviously here, getting a lot better kill. Obviously the concentration would probably be a lot higher at this state here, and you can actually go down and look to see what the actual concentration needs to drop down to in order to see where the bacteria start to grow again, right? You can actually see the specific concentrations. We will use that concentration and then link it back to, well, what kind of concentrations do we get in that patient, and try to correlate those together to say, well, okay, what kind of a dose do I need to give to get that level to kill off those bacteria, right? Remember that therapeutic drug monitoring we talked about? A lot of it goes back to that and look at measuring these drug concentrations to see what's going on, right?
If it's bactericidal, not bacteriostatic.
We'll talk about that in a minute. Yeah, so a lot of that goes back to the mechanism, though, specifically how the drug is affecting the bacteria. We'll talk about that. And of course, resistance is a huge, huge problem we're dealing with, right? So again, if it's not the zombie apocalypse or nuclear war, probably the superbugs are what's going to kill off humanity, if I had to guess, right? Those are my 3 bets currently going forward. And so again, we're based on these emerging resistances, we're finding that there's some strains of bugs that our antibiotics just do not work on, right? Or in order for them to work, we'd have to give such high concentrations, we're probably also going to kill off who? The patient, right? And typically not good, right? For the most part. Now, how you decide your antibiotic should not be with this method here, right? You don't want to just throw something at a wall and see what sticks, right? You actually want to make good informed decisions about what to use, right? So this is where we're going to get into talking about things called empiric coverage. When I say empiric coverage, what do you think that means? Yeah, so start talking about, okay, if I have a particular infection, say it's a skin infection, what are the most likely bugs? What are the drugs that's going to have a wide enough spectrum, right? When I say spectrum, it basically means the group of bugs that antibiotic is going to be able to attack. Say, okay, well, what do I need to cover to make sure that I'm most likely going to be able to treat this infection? And then go from there, right? So we'll talk about that process in just a few minutes here, but that's what we call empiric coverage, right? Typically, when we talk about spectrum, we're going to use something that has a broad spectrum initially, and then as we get better information about what specific bacteria is causing that infection, we can narrow it down to get more narrow spectrum, right? That's always what you want to do. You always want to start broad spectrum and you narrow down as much as you can, okay? That's a good rule of thumb. So why is this a concern? We have things like, MRSA is becoming much more prominent. So the more MRSA, meaning you need bigger guns. I talk about guns as far as antibiotics go. I talk about things like, penicillin, our first antibiotic we ever had. It's kind of like a little pea shooter, right? It's not a very good gun. We have some things that are like a bazooka, right? That will basically wipe out everything in the patient. C. diff is almost guaranteed. But sometimes you need those really big guns to clear an infection. That's due to things like MRSA being more prominent. We have things like vancomycin-resistant enterococcus. When you see VRE, that's what we're referring to, and I'll cover that a little bit later. Things like vancomycin-resistant Staph aureus. Vancomycin is a very good killer of gram-positive bugs. Sometimes even that's not going to be adequate, right, with these resistant patterns that develop. The other big problem are going to be our gram-negative bugs, right? So we're going to have things like ESBLs. This basically stands for an extended spectrum beta-lactamase. I'll talk about what beta-lactamase is in a few minutes here, but it basically means that things like your penicillins aren't going to work anymore, right? We also have things called Klebsiella-producing carbapinamases. We'll talk about that just a little bit later, but again, that also will make sure that your penicillins and other drugs that are related to penicillins don't work anymore, right? And once you lose those, you lose a huge swath of drugs that you can use to treat that infection, right? The problem with gram-negatives too is they like to share data with one another, right? So just like you guys probably share notes on a Google Drive, they do the same thing where like Klebsiella will say, hey, I got this carbapinamase, let me shoot it over to you, E. coli, and then E. coli is like, great, now I'm resistant too. They shoot it over to Acinetobacter, and it's like, great, now I'm all resistant, now our patient's dead, no, can't live anymore. But then they pass it on to the next patient, gets rolled into that room maybe. That's a really big problem with a lot of gram-negative bugs. And so things like Klebsiella, E. coli, Pseudomonas, Acinetobacter, these are oftentimes what ends up leading to a patient's demise when they're especially in the ICU. They develop pneumonias from these. They get sepsis related to that. Very, very nasty bugs. Okay. And again, what causes resistance? A lot of it goes back to indiscriminate use of antibiotics, right? So a patient comes in, they feel really crummy, got a runny nose, maybe a low-grade fever. They come in to see you, and what do you think it is right off the bat? It's a bacteria, virus. Most of the time it's a virus, right? So especially a lot of these ENT complaints, they're going to come in, you're going to say, hey, well, it's a virus, right? And so you can tell your patient that it's a virus. You should, just hydrate up, be fine in a couple of days. Are they going to be satisfied with that? A lot of times they may not. Like, no, I want a Z-Pak. I want some Levaquin. I want something to be able to treat this. And you say, well, you don't have a bacterial infection. Yeah, but last time they gave it to me and it worked great. After a couple of days, I felt better. So let's do that again. That is indiscriminate use of antibiotics, right? And I'm going to try to train you guys to make sure you're not going to be using those inappropriately. So make sure you're following guidelines. Make sure you're looking up in your references to see what are the #1 recommended first-line drugs for something, and go with that. There's no reason to buck the trend or try to use something different because they've already done the work for you. They've already looked at the data and said this is the best way to start, right? Things like double covering. When I say double cover, what does that mean? Yeah, 2 antibiotics to cover the same bacteria. There's very rare instances where that is good, where you want to do that. The majority of the time, you don't need to, right? You just want to have one drug that's going to be able to cover basically what you think is infecting your patient, and then you can reevaluate later when cultures and things like come back. That also kind of feeds into the not de-escalating or streamlining therapy. That goes back to that spectrum where you want to start a broad spectrum and kill a lot of different types of bugs, and then once you know what your patient's infected with, whether it be MRSA, whether it be E. coli, Klebsiella, whatever, and then narrow it down to just use something that's very narrow that would only attack that particular bug and kind of spare everything else that is maybe there, maybe a communal sort of bacteria that should be there. Other things, prolonging antimicrobial therapy, so treating longer than you need to. So that's another big component of looking at antibiotic prescriptions is to say, well, how long do I need to treat this? Is 5 days appropriate? Maybe I need 7 days. Maybe I need 10. Maybe I need 14. You find some infectious diseases like TB. TB you have to treat for months and months and months, like 6 months in some cases, right? Or even longer, depending on the patient. So again, be cognizant of the durations of therapy. If you go too short, what can happen? You get more resistant bugs, but they also are going to populate again, so the patient remains infected. Or on the other side, if we go for too long, resistance is going to be the big thing. Your patient will probably be cleared of the infection. However, you can see that emergence of resistant bugs there. Okay. Other things, anytime we are putting foreign objects into our patient, we run the risk of developing an infection, right? So if I put an ET tube into my patient and they're on the ventilator, say for greater than 7 days, guess what? Little bacteria start to develop on that tube and then go crawling down into the lungs, and guess what? Now you have ventilator-associated pneumonias, right? If I put a Foley catheter into my patient and it resides there for days, weeks, months in some cases, you're going to find little bacteria going to crawl up into the urinary tract, and guess what? And they have a nasty UTI, maybe it's turning into pyelonephritis, whatever happens to be. Anytime you're putting foreign material in, that is a possible surface for those bacteria to grow. We don't want that. Anyone know what the term for that is? Fomite. If you ever hear fomite, that's probably something you'll hear in micro, but that's something that those bugs can grow on, basically, that is not normally there, right? Again, prolonged hospital stays, the longer you're in the hospital, the more likely you are to develop infections that you then have to treat that as well. And then the other big thing is looking at prior antibiotic use. So anytime you're dealing with a patient coming in what you think to be an infectious complaint, you want to see what have you taken recently, what have you taken in the past, right? So of course you're going to ask about things like allergies, obviously, because that may preclude you from using certain antibiotics. But you want to see like, okay, well, did they receive, they're coming in for acute otitis media, they were just treated last month with this drug. Maybe that really wasn't that effective. You may want to use something different, right? You don't want to use the same thing every time because you may find it's not going to be all that effective due to that resistance, right? And then also using antibiotics prophylactically when it's not indicated. Because when I say prophylaxis, that means what? Yeah, giving it before the infection occurs, right? So again, there's certain instances where you want that to happen, where you want to give prophylactic antibiotics. Surgery is a great example. You want to give antibiotics to your patient prior to surgery. If you're cutting them open, you can introduce all sorts of bacteria there. But in a lot of cases, you don't need prophylactic antibiotics, okay? So it's important to know when that's appropriate or not. And then using too broad a spectrum, this is where I'm talking about the really big guns, like the nuclear bombs of antibiotics, things like meropenem, cefepime. We'll talk about these in more detail. But overall utilizing these tends to be another big source of resistance as well, okay? And then things like, the meat that we're eating, you tend to be treated with a lot of antibiotics. So you can see things like resistance developing from there. Anytime you see MDR, anyone know what that stands for?
Multi-drug resistant.
Yep, multi-drug resistant bacteria. So oftentimes you can find that actually being spread from animals, and that can affect us as well, right? So I'm not going to get into the specifics of how, and I'm not going to ask you on a test specifically, how do bacteria develop resistance to these drugs, but it's kind of good to know the different ways that this can occur. So just to give you some examples, in some cases you may find that the bacteria can actually mutate its target. So for instance, if I can mutate things like the DNA enzymes that are affected by a class of antibiotics, you can find that this will then confer resistance against them, right? So in this case, when we talk about the quinolones, we're going to talk about that they affect DNA. If you change that enzyme just enough to where the clones can't bind to it anymore, guess what? Drug doesn't work, okay? And that means that you can actually confer resistance across a whole class of antibiotics, right? So just because I give someone levofloxacin, they develop that resistance, now they're also resistant against ciprofloxacin and moxifloxacin and all the other groups that fall, or the drugs that fall into that category, right? So these are things you have to consider. Sometimes you can have increased expression of efflux pumps. Efflux pumps will do what to us? Or do what for the bacteria? Just pump it right out, right? So again, that way it says, hey, I don't want this antibiotic in here. Let's go ahead and pump these out, and that way the bacteria can continue to grow and do its thing, right? Other cases, you may find that the drug, the bacteria can actually degrade the drug itself. So this is where when I talk about beta-lactamases, this is where the bacteria can produce an enzyme that will actually destroy the drug and make it ineffective. Okay, so these are all good examples of ways that the bacteria can modify themselves and develop these resistance. Okay. And there's different ways we can try to manage this. So doing things like following guidelines. Sometimes we'll actually have cases where we actually will rotate which drug we use for certain indications. So for instance, if I'm working in the ICU and we're using a lot of gentamicins, an aminoglycoside antibiotic we'll talk about later, but I say, okay, we'll use this for 6 months. Now let's switch over to tobramycin. Sometimes that allows us to bypass some of that resistance and allow the bacteria, whatever's growing there normally, will then kind of start to lose that resistance to gentamicin. And then when I reintroduce it a year later, it's going to be sensitive again, right? So sometimes we can do things like that. Sometimes you have a really nasty bug that will basically infect an entire unit. Sometimes you have to have an entire terminal unit cleaned out, where you basically will move all the patients out of the unit, do a terminal clean, and then get them back in. And those are rare, but those can happen. We have really nasty resistant bugs developing. So lots of different things to do, but basically follow your guidelines, follow the first line treatments. You generally can't go wrong by doing that. Okay, that's good for empiric therapy, as we're talking about here. Okay, so let's do a 10-minute break. We'll come back and then start talking about the drugs. Okay, so getting into any questions from the first half. Again, I know these are kind of broad topics, but we're just about to drill into the drugs here in just a moment. Okay, so looking at how we choose our drugs, like what are the things that go into the decision-making process to say, I want to use this drug to treat this patient's infection, right? So first off, spectrum of activity. We mentioned that is what? This goes back to that spectrum of how big a gun it is. How many different types of bacteria is it going to treat, okay? So again, spectrum means, okay, well, I know that something like vancomycin, we're going to talk about extensively about vancomycin, that only treats gram-positive bugs. So if I think my patient has a gram-negative infection, I'm not going to use vancomycin for it because I know that's just not going to cover, does not have the right spectrum to treat that infection, right? So you need to know what you're treating. The kinetics actually make a big difference here, right? So again, I'm sure most of you have dumped most of your kinetics knowledge. We're going to drudge it back up from the depths of your subconscious, don't worry. But things like absorption, right? So again, does the drug actually get absorbed into the body via whatever route I give it by, right? So how do we give antibiotics? What route? PO. PO is a very common one. Probably use that most commonly in the outpatient setting. So does it get absorbed through the GI tract? We need to find out, right? I mentioned IV. IV is another common one. IM. So again, thinking about the absorption, how well these drugs are going to get to their site of action. The big thing that we'll also focus on is going to be the distribution, right? So do the drugs actually get to the site of action? Okay. So for instance, if I'm treating a UTI, where do I want that drug to go to? Probably to the urinary tract, right? But if I have a drug that is 100% metabolized in the liver and never makes it to the urinary tract, is that going to be a very good drug? Absolutely not, right? So you would not want to use that. So you'll sometimes find that specific drugs cannot be used for an indication due to the fact that it just doesn't make it to the site of action, right? Other areas can be very difficult to penetrate. So for instance, the lungs are a difficult area to penetrate. Certain drugs have an easier time getting to the sites than others. Sometimes we can modify that by increasing the dose in order to get a higher concentration, but sometimes we just have to choose a different drug altogether. Another big place, what area of the body is exclusively meant to keep things out? Blood-brain barrier, absolutely. So the CNS is a very difficult area to penetrate with most drugs. And either things are too big, they're not lipophilic enough, or we have those efflux pumps that are going to shunt stuff back out of the CNS because we want the CNS to stay pretty much as is. We want to keep things out of it. However, when you have something like meningitis, you have a lot of inflammation. Sometimes you'll find that certain antibiotics can get through easier, right? Because when you have inflammation, you have swelling, you have those gaps open up and it makes drugs have an easier time crossing over, right? So sometimes you'll find that specific indications will require certain drugs based on that distribution, okay? And then elimination is also quite important, right? So the two main organs of elimination we've talked about are what? Kidneys, right? So you have to monitor for kidney function for a lot of these antibiotics, and you're going to learn about these over time, but the best thing you can do whenever you prescribe an antibiotic is guess what? Look it up, right? Look to see if there's renal dosing available for that, based on your patient. If you suspect they have renal issues, right, their history of it, or you suspect now they have renal problems, you need to look that stuff up to see, do I need to adjust the dose? Maybe I need to give it less frequently. Maybe I need to give a lower dose, whatever the case may be. The other big organ is what? The liver, right? So we can have some excretion from there, but most metabolism happens there. If you have a patient with really severe liver dysfunction, that may not be a good drug for them, depending on what you're trying to choose, okay? So these are things to consider. We're going to get into the pharmacodynamic aspects of it. So for instance, whether something is bactericidal versus bacteriostatic. Anyone know what the difference between those two are?
One inhibits growth, one kills.
Which one kills the bacteria? Bactericidal, right? So things that are bactericidal are going to kill off the bacteria versus things that can be bacteriostatic, which are going to do what? Yeah, just basically just inhibit the bacteria from growing any further. So, you know, if you have a patient who has a really competent immune system, that's fine. You can use bacteriostatic drugs because they're going to have an immune system that can come along and fight off those bacteria, no problem, right? However, if I have a patient who has a very poor immune system, like who might have a poor immune system? So like cancer patients who are on active treatment, right? HIV patients who are more progressed and maybe their CD4 count's pretty low, right? These are patients who are going to have a poor immune system. They may not have the white cells basically to fight off that infection. So in those cases, I may choose something that's bactericidal in order to give them that extra boost to clear that infection, right? These are things you'll think about depending on the patient population that you deal with on a day-to-day basis, right? So for instance, someone who works in the ER has a very different set of antibiotics that they do on a routine basis than someone who, say, for instance, works in the hemat clinic, right? So you'll get used to that depending on where you work, and you'll see that on rotations as well. We're going to talk about time-dependent versus concentration-dependent killing. This is also something we'll consider. I will talk about this in more detail in just a few minutes, but we'll come back to that. And then the other big thing is toxicities, right? So looking at things like, what kind of GI toxicities are we going to have? There's a lot of skin manifestations that can come about from these antibiotics, whether it be photosensitivity, right, which is a big deal, especially here in Florida. We have a lot of people going outside, a lot of sun. You can see things like rashes. Anyone ever heard of Stevens-Johnson syndrome or toxic epidermal necrolysis? This is a rare consequence of some drugs. When I note those, that's something you'll probably want to know about, right? Because of the fact that it is so serious that you need to educate patients. Hey, if you start to notice all these blisters and your skin looks like it's falling off, you should probably go to the ER. Otherwise, it might be, oh, that's just weird. That's normal now. I guess I'm older. Maybe the skin falls off now. No, you need to go to the ER, right? Those are things you need to know about. Hematologic complications like anemias can develop here, thrombocytopenia, etc. CNS problems. Sometimes we don't want to use certain drugs in patients because they can develop CNS issues like altered mental status, seizures, depending. Hepatic cardio is another big thing I should have put on there because you can see a lot of cardiotoxicity depending on the drug we're going to talk about. So when I harp on something as far as from a side effect standpoint, those are the things you want to know about. Because again, I can say nausea, vomiting for every single drug out there, but that's not really super useful for you to sit there and think about, okay, this one causes nausea, vomiting, so does this one, so does this one. I don't really care that you know that. Just know that generally, most drugs can cause nausea and vomiting, right? Now, specifically, if I say this one in particular causes a lot of diarrhea, that is something that you would then want to kind of focus and key in on, okay? All right, so I mentioned bactericidal versus bacteriostatic. Well, a lot of it deciding which one is which is going to go back to the actual mechanism of the drug itself. So for instance, if I have a drug that comes and breaks down the cell wall, that cell wall then lyses out all the content of the bacteria. Do you think that's cidal or static? That's pretty cidal, right? So again, if I ripped a hole in you, you'd probably die as well. I'm not going to do that, but you can at least make the association in your mind, right? So again, we'll talk about things like penicillins, cephalosporins. They're going to be working at the cell wall to actually break that down, and then you can kind of make the logical conclusion that yes, that is going to kill that bacteria off, right? We're going to see the things that do not kill the bacteria tend to do things like affect things like protein synthesis, right? So if I just stop the bacteria from producing certain proteins, then the cell can still live for a while. It still has a pretty healthy store of proteins it's already using. It won't kill it off, but it may prevent it from developing new bacterial cells, right? You can't really have that mitosis occurring there. And we'll talk about specific examples as we go forward, but have a general idea when we talk about them. Hey, is this bactericidal or static? And we'll have a good idea of that when we talk about the individual mechanisms here as we're going forward. Okay, so concentration versus time-dependent killing is something that you'll hear about occasionally. When I say concentration-dependent killing, what do you think that means?
Concentration.
It's dependent on the concentration, as you might imagine, right? So the higher the concentration, the more bacterial kill I'm going to get, okay? So this is something that I may only want to give a really big dose of the drug to, and then I don't give it very frequently. So for instance, I can give a really big dose of a drug one time a day, get a really big peak, and then that kills off a ton of bacteria, and then I let that level get down pretty much to zero before I give the next dose, okay? We'll look at some graphs here in a second to kind of show you that. That's going to be concentration-dependent killing. They have what we call a post-antibiotic effect, where even if the level of that drug gets down below that minimum inhibitory concentration, that MIC, right? That's that level that the drug needs to be above to kill the bacteria. Even if it drops below that, it still ends up killing off that bacteria. Maybe the bacteria have already soaked up some of the drug, whatever the case may be, but it's still killing off that bacteria. That's concentration-dependent killing. On the other hand, you have time-dependent killing, and so what do you think this means? 100%. So the longer you keep the drug above the MIC, the minimum inhibitory concentration, the more bacterial kill you're going to have. Okay, so this means that I can't just give one really big dose one time a day, because by the time I give that next dose 24 hours later, that level's negligible, zero practically, right? However, I can give it more frequently in order to keep those levels up above that MIC for a longer period of time, right? So a lot of good examples are going to be like the penicillins. They're going to be time-dependent killers. They need to be above that MIC as long as you can, which means we have to give it more frequently, right? I give a smaller dose, but more frequently to keep those levels up. So again, if you remember going back to those graphs we had in Pharmacodynamics, remember there's, we talked about steady state concentrations. You remember that? Right, that same average steady state. I could either give something at a big dose, give it very infrequently, and again, I apologize, my handwriting has not gotten any better over the past 2 weeks, or I can give something more frequently, right, and I can keep those levels roughly the same average, but you're going to find that if the MIC was, say, for instance, right here, and again, there's probably something you could say about my developmental skills or something based on this. But anyway, but anytime if you had a time-dependent killing antibiotic, anytime it drops below that green line, it's going to stop killing those bugs. And guess what happens at that point? they start to grow again, right? And then you can either develop resistance or they come back and they continue to grow. So you don't want that. You want to keep it above that MIC as long as you can. And so those are typically drugs we give more frequently. So it's maybe every 8 hours or every 6 hours or whatever the case may be, okay? Good concepts to remember. And again, when you're looking at different concentrations of bacteria, and these you can see here that as you increase the concentration of antibiotic in these, you're going to notice that they get clearer and clearer as you're killing off more of the bacteria. So we use these sort of things to determine kind of what concentration of drug we need to kill those bacteria. Yes, sir. Jeff, question? Yep, I'll show you that right now. So basically what we're looking at is going to be another term we'll use is called area under the curve, which basically means how much time that antibiotic spends above the MIC. So in this case, you see this MIC right here, and we can actually determine what that concentration is. We can determine how low we can drive that concentration before we start to see bacteria start to grow again. Because if I drop down to 2, you start to notice it gets a little more cloudy. If I drop down to 1, it gets even more cloudy. That shows that the bacteria are growing in those cases there. So if I have something that's going to be, say, a time-dependent antibiotic, what you're going to find, so when we're talking about beta-lactams, this is going to include like our penicillins and cephalosporins, you're going to find that you are going to see that as you get the level above the MIC, you're killing bacteria, and then once you drop below this line, now the bacteria can start to grow again, okay? It does not have a post-antibiotic effect. It does not have continued killing once it drops below the MIC. So we need to give another dose in order to keep it higher than that, okay? On the flip side of that, say we had something like an aminoglycoside like gentamicin, we can give just one-time dose to get it well above the MIC, get a really high concentration here, and then even though it drops down below the MIC, you're still seeing those bacteria. They're not growing, they're not replicating, they're continuing to die off. Okay, make sense? Yeah, it's kind of like, almost like shocking the system. Like I'm just going to give you like a really big dose, and all of a sudden the bacteria are like, whoa, I can't continue to grow, or they're being killed off, or whatever the case may be, and then by the time they get another dose, when that post-antibiotic effect would wear off, then you're giving another dose and shocking them again, essentially. Okay. Okay. So here's a good table showing you the different categories of antibiotics, so you can kind of get an idea of where their different sites of actions are going to be. Now, in the case of if I had to use 2 different antibiotics to treat a particular infection, would I want to use the same target for both of them, or would I want to use, say, different targets? Generally want to use different targets, right? So when we talk about things like double coverage for certain bugs, which is going to be rare, but we'll talk about it, you typically want to use different mechanisms of action, right? So if I have one drug working at the cell wall, then I want something working also on the DNA, or I want something working on the protein synthesis or something like that. By doing that, you get synergism, right? So even if maybe, for instance, the bacteria was resistant to the cell wall active drug, guess what? You got another one that's still attacking a different mechanism that's still viable, okay? So again, oftentimes if you're going to use more than one drug, you want to use dual mechanisms, not the same one. Otherwise, you're going to be just, not really getting a whole lot of bang for your buck at that point. You're just increasing side effects. Okay, that makes sense? We're going to talk about all these in much more specific detail, but this is a good table we can go back to, or good graphic. You can kind of break them down into their component categories and kind of where they're working at within the cell. Okay. So first ones we're going to talk about are going to be agents that affect the cell wall. And again, this is kind of starting with our most basic first antibiotic we ever had and kind of progressing from there. And so you're going to find that there's a lot of drugs, right? We're going to talk about a lot of drugs. You're going to memorize all sorts of different drugs here, and you're going to never dump any of this knowledge ever. You're going to know it in perpetuity, right? Forever and ever? No? Okay. Well, anyway, you're going to learn a lot of them. But again, it's good to know categories. Like, how do you lump these together into things that share similar characteristics, because then you're going to be able to recall that. Because I will tell you, when I write test questions, basically I'll come up with, sometimes I'll have an easy question where it'll be like, which one of these drugs affects the cell wall? And you say, okay, well, I know it's either like a cephalosporin or penicillin or carbapenem, something like that, and you're going to see 4 drug choices. Almost pretty ubiquitously, you're going to find that most of my test questions just have 4 drug answers, and you have to select the best drug for that case, right? So you may just select, okay, this one's a cell wall inhibitor, I know that's the right answer, okay? It gets more difficult than that, as you might know. I don't know if you know this about me, but I do write some difficult tests. I don't mean to, but it just happens. But basically, you're going to find that I will have things like clinical vignettes. I will have something like, hey, you have a patient who comes in, and again, I'm not big on making the diagnosis, right? I'm a pharmacist. So I take your diagnosis, and then we go with treatment after that. So we'll say, okay, you got a patient who's got acute otitis media. Based on the fact he's had antibiotics in the past week, what do you think is going to be the right drug for them, right? And so you have to make a decision. Okay, well, based on contraindications, based on allergies, based on previous antibiotic use, I know that this is going to be the right drug. That sounds intimidating, but we're going to get there, right? We're going to go through these steps and to figure out how do we make that decision. What's the process to decide this is the right drug for this patient, okay? And again, Kahoot's going to help us with that. We're going to learn to see some similar questions. What am I asking on the test? And that hopefully will alleviate most of your fears, right? I hear this first test is super easy though, so just kind of feel confident, right? Okay, anyway. So we're going to look at drugs that initially affect the cell wall, because again, if you had to think about it, if we're affecting the cell wall from disrupting that, these tend to be bactericidal. These are going to kill off the bacteria quite well. And so we're going to run into some categories. So the first ones we're going to talk about are going to be our beta-lactam antibiotics. I'll tell you what that means in just a second here. This is where we're going to see our penicillins. You're also going to have things we call our cephalosporins. You probably know a lot of cephalosporins, just don't even know that that was the category they fit into. You're going to look at the carbapenems and then the monobactams, right? And you notice the cephalosporins are going to have their individual generations that they'll be broken down into as well. So we'll cover kind of the more common ones you're going to run into on a day-to-day basis. Also going to have some other drugs that work via a different sort of mechanism. It's kind of similar. They still affect the cell wall, but not the same way the beta-lactams do. But this is where we're going to see things like bacitracin. Who's ever used bacitracin before? Anyone ever had a boo-boo? Right? Just rub it on your boo-boo and then you're all good to go, right? So we're going to find that that's going to be affecting cell walls. Vancomycin is a very common one you find in the hospital, and then daptomycin is another one you may see used a little bit more selectively. These are all cell wall inhibitors. And then we're also going to talk about the beta-lactamase inhibitors as well. So this is another important group of drugs that you'll sometimes see used in combination with the actual antibiotics. So getting into it, we talk about beta-lactams. The first thing we're going to have is penicillin here. And usually when you see penicillin structures, you notice this little kind of square sort of ring here. This is the beta-lactam ring. This is the business end of the penicillin, right? The penicillin sort of molecule. You notice this R chain right here? When it says R there, for my organic friends, what does that mean? Just some different functional groups. So again, you're going to find that the majority of the beta-lactams tend to share this similar structure. They're all going to have that beta-lactam ring. That's what makes them beta-lactams. But you're going to find the side structures are going to be what's different, right? So for instance, the R chain can change here to either make penicillin, or it can make amoxicillin or ampicillin. And again, I'm not going to have you draw these on a test by any means, but I kind of want you to get a feel for why do we call these beta-lactams? What is different between these? Because again, we talk about allergies. Allergies are very important, right? Because again, if you say someone comes in and say, oh, I have a penicillin allergy. Well, you want to be able to determine, well, what does that mean? Does that mean I can't use any penicillin on them? Does that mean I can't use any other beta-lactam on them? We will talk about that, right, and some more detail on that in a few moments here, okay? Their mechanism of action, and what you notice here is that the beta-lactam ring actually mimics these two D-alanines. So normally when you have the cell wall being produced in a bacteria, they're going to have these two D-alanines that get added together. And you can kind of see how they kind of share somewhat of a similar structure, right? I'm not going to have to bend your mind that much to really figure that out, but just know it kind of looks like two D-alanines, right? And again, it shares that similar structure. So what it's going to do is it's going to link to this enzyme this cross-linking enzyme called penicillin binding protein. Penicillin binding protein is pretty easy to memorize its function because guess what it does? It binds to penicillin, as you might imagine. So, okay, that makes sense. So it will accidentally bind to penicillin, and then when it does that, it causes a covalent linkage, which makes it so that it'll inactivate the enzyme. So if the penicillin binding protein is not available to make these interconnections within the bacterial cell wall, guess what? The cell wall breaks down. It can't make these cross-links. It's going to open up, and then it spills all the contents out, and boom, your bacteria is now dead. Okay? This is the primary function of how any of your beta-lactams are going to be working. Yes, sir?
What do you mean by accidentally binding?
Just through random diffusion. So again, as I add a drug, again, molecules are just kind of bouncing around. Eventually, at some point, the enzyme is going to link to that penicillin, again, assuming the concentrations are high enough to actually cause that meeting to occur. And again, you can make that meeting occur more readily if you add more drug, right? But of course, there's always the risk of more toxicity occurring there, right? So if the concentration of the penicillin gets high enough, you're going to find that most of the penicillin binding protein molecules actually become inactive. And so you can see some of these cross-links that are being made here. And so if you inhibit that enough, they can't make new cross-links. You start to see this degradation where the actual cell is then going to rupture. It's going to allow these contents to spill out and the bacteria is now dead. Okay. Again, this is going to be the primary mechanism for all of the beta-lactams we're going to talk about here, right? Whether it's penicillin, whether it's cephalosporin, whether it's carbapenem, any of them all work the same way. Okay. So the first ones we're going to talk about are going to be our natural penicillins, and I like to use a stoplight sort of methodology to give you guys some kind of broad strokes as far as what sort of bugs that these drugs are going to cover. Now, is this absolute? No, but it's a pretty good, at least first kind of pass at trying to give you some ideas of, okay, what kind of bugs do these drugs actually cover here? Okay, so for instance, if it has yellow light, does that mean it's going to cover it very well? Kind of iffy, right? So it's not like a normal yellow light where you just gun it, right, and you just give a lot of drug and hope it works. Like, you don't want to do that. Probably not going to use it for most indication. Maybe some exceptions, but you're probably not going to use it. If it's red, I'm not going to use it, right? So again, it's going to have no appreciable coverage for gram-negative bugs. I'm just not going to use it for that indication. If it's green, though, green's good to go, right? So again, I could use potentially penicillin for a gram-positive bug or gram-positive infection, okay? Now again, there's going to be some limitations here as we'll talk about, and again, things like MRSA is going to be important to note. Things like Pseudomonas, so kind of keep your ears perked up for those kind of buzzwords, right? Those buzz bugs, as it were. So anyway, the first one we have is penicillin G. This is the OG penicillin G, right? The first one you get. You probably have some growing in your refrigerator, perhaps, maybe. So you guys keep it really clean. Typically, you're going to find this actually has some pretty good coverage against many of gram-positive cocci. However, it doesn't really have good coverage against staph. It's important because, again, if you have someone who comes in with a cellulitis, like, they probably are going to have some staph that's going to be involved in there. At least you don't know, right, just looking at the patient. And so in some cases, you're going to say, well, maybe penicillin G is not going to be a good drug for that. It just doesn't have wide enough coverage in order to treat that. You notice in general it does not have any kind of anaerobic activity, except it will cover some bacteroides. And again, this is pretty narrow spectrum as far as most antibiotics goes. We're going to find penicillin is pretty narrow. However, we can use it as a drug of choice. And again, you're going to find that for different sorts of infections, there's going to be certain drugs of choice, right? So for instance, if you get syphilis, I don't recommend it, but if you ever get syphilis, penicillin, a shot of penicillin is going to do you just right? That's going to be recommended. In some of these cases, you can find that even over time, even using it for decades, the bugs never develop resistance against those cases there, right? So we can still use penicillin for syphilis. In general, you don't find it to be a big issue. Yes, ma'am. It's well, it said it's no good for anaerobe, but it only covers bacteroides. That's why it gets that yellow light there, because it only covers one particular anaerobe, right? So if, for instance, if you think back to that anaerobic slide and you had, say, like Clostridium difficile, this wouldn't cover that, right? So I could not use this for a C. diff infection. The infection would just continue growing unchecked, essentially, right? Because there's no interaction here. Things like gas gangrene, meningococcus, these are good choices for penicillin G. You're going to find you don't really use it that frequently. There are some specific circumstances, but you'll learn this as you go through CMS and learn about different infections, right? And again, no real good activity against gram-negatives, so I would never use this for like a UTI. I probably wouldn't use this for, like a pneumonia, things like that, because I know this doesn't have wide enough coverage to really get those, okay? Now, I'm not going to have you memorize doses, so you can breathe a sigh of relief for that, right? You'll get that later, you get those in other courses. But I do want you to kind of note some of the things here, right? So for instance, like, notice how we dose this. We dose it in units. Right, so again, most drugs tend to be dosed in milligrams or grams. This is one of those instances where it's not the case. So you have to write out, 18 million units given every 4 hours. And what do you notice about that every 4 hours? Why is that significant? The time-dependent killer, right? So you could not say this is a concentration-dependent, because if I just gave one big dose of penicillin G, guess what? The concentration get too low. I'm below the MIC, the bacteria can grow again. But by giving every 4 hours, I get that level up high enough, and then to stay above the MIC for a long period of time, I continue killing the bacteria. Okay. Now, is it really convenient to give a drug every 4 hours? Right. It's really convenient. 6 times a day. I don't want to do that, right? In some cases, we'll actually have to give this as a continuous infusion. We'll run it for 24 hours straight, depending on the infection. So it just depends, right? And so, again, as far as monitoring goes, not a whole lot. Obviously, monitoring for the signs of infection to see if the patient's clinically improving. Is their fever getting better? Is their white count going down? This is going to be ubiquitous amongst all the antibiotics as far as how to monitor for efficacy. But also, things like anaphylaxis. Patients do have a tendency to have a reaction to penicillins. Now, when you have a patient comes in and they say, "Oh, I have an allergy to penicillin," what's the next thing you want to ask them? What kind of reaction you had, right? So they say, "Oh, I got some diarrhea." Is that a true allergy? No. If they said my throat closed up and I needed epi and a crike. Yes, that is a true allergy. That is not something you want to re-challenge that with, right? So again, depending on what the reaction actually is, you can try to challenge them, right? So again, I have a lot of providers who will say, well, this patient says they're penicillin allergic, but they said they got it as a baby. Their mom told them that, and they've been carrying this with them their whole life. I said, well, let's just give them a dose in the ER. Right? See how they do, because guess what? If you're going to have an anaphylactic allergy, where would you want to be? In the ER. We can treat you, right? So sometimes they'll feel more comfortable with that. Not that I'm trying to say. Now, if they have a really high likelihood of having anaphylaxis, I'm not pushing for them. Just give it. Let's see them anaphylax. But if it seems pretty bogus, I'm going to say, hey, let's at least challenge them. Give them a dose here, see how they react. If not, then they can go home with the prescription. The problem is once you say you're allergic to penicillin, that means all penicillins tend to cross-react, right? So that means that you wipe out a ton of different drugs that patient cannot use anymore. Okay, you do not want to do it. You want to keep your options open as best you can. Yes, sir.
What's the effect that will have on patient satisfaction if, like, they're like, I don't know my reaction, but I was told as a kid, and then they bust out in hives?
Yeah, so you're going to feel pretty goofy, right, if you actually do have a reaction. But then you actually have good evidence to show that, yes, you do have a reaction to this. I probably do not want it. So if they had hives, that would probably not be one that I would want to continue with, right? In those cases, though, that's good documentation, right? So now they can take that with them and say, okay, well, I never need to receive a penicillin ever again to know this. But otherwise, if you have a patient comes in and like, I don't know what my reaction is, my mom just told me about it, they can go a whole lifetime without receiving those, and that could be life-saving antibiotics potentially for that patient, right? So risk versus benefits, always what it comes down to. I wish I could give you, yes, this is the patient you should challenge, this patient you shouldn't, but challenging in the ER does give you that benefit of being readily available access to anaphylaxis meds and airways and all kind of good stuff, right? So we'll talk more about allergies as we go later on, but it's kind of a it's always a hot topic to talk about, right? Because again, you guys want nice clear-cut answers, and there's not going to be a lot of good answers for when it comes down to this. Anyhow, some other forms, right? So again, we have penicillin G. That's the regular form, but this is actually only going to be able to be given IV. If you put penicillin G into the GI tract, it gets broken down by the stomach acids and whatnot. So it's actually no good. And so we have different dosage forms in order to get penicillin into the patient. So one for examples is penicillin VK or V potassium. This is the oral form. This is one you can actually give to a patient, and it's stable in the stomach acid, right? So you may see that. We have one called benzathine penicillin. I'm sorry, penicillin G is the one we give IV, and then we have benzathine penicillin G here. This one's known as bacillin. This is actually a really good one we use in the ER quite frequently, but it's only good for IM administration, right? So that means it goes where? Into the muscle, right, as you know. The reason why they call it bacillin, and sometimes you'll see bacillin LA, and you kind of see that on the syringe there, that means long acting. So this is a really good one. So if I have a patient who we see this very frequently where a patient comes in, say for instance for strep pharyngitis, right? So say they're traveling from out of state, they're there for their Disney trip for the summer, and they get strep pharyngitis when they're in the parks, right? And they're throwing up and they can't tolerate anything orally, but they want to get back out of the parks, right? The kids. Parents have spent a ton of money to come down here, and now they're in the hospital. What the heck's going on? So what we'll do sometimes, instead of trying to give them oral antibiotics that they can't swallow, we'll actually give them a shot of bacillin, and that way it lasts long enough to where they only need one dose, and they can go back and go do their thing, and they're good to go. So sometimes choosing the dosage form can be very dependent on what the patient's situation is, right? If they can tolerate oral, they'll give them oral penicillin. Otherwise, maybe they need an IM shot of it, right? So it all goes down to the patient specifics.
But wouldn't the penicillin VK have less distribution since it should go through the first pass effect, correct?
Well, yeah, so that's a good point. So yes, you would have you run the risk of some first pass effect, right? But the question is like, well, how much first pass effect does it have, right? So some drugs you may have almost zero, some drugs may have 100%. It's all going to be gradations. However, when you are looking up the dosing for your patient, they've already taken that into account, right? So you may see that if you see oral doses are higher than IV, they're usually taking into account things like, drug loss in the stomach or drug loss in the liver, et cetera. Okay, so that's why I always want to make sure not just assume that IV to PO dosing is the same, because very frequently they're not. Okay.
So the only difference between benzyl penicillin and bacillin is just the route.
Yeah, basically. So the thing to note there, that's a good segue, is notice what color is this? White, it's kind of milky. They have to put it into a lipid base, basically, right? Anytime you see something white and milky, that's usually a lipid that it has to be solubilized in, okay? So the point with bacillin is you can inject it into the muscle, and that's why you only give one dose of it, is it'll slowly leach out that drug from the muscle over a long period of time. The problem is for some of these drugs that come in these sort of bases, if you give that into the intravenous route, and these nice big lipid molecules get up into the lungs, what can happen? Block off some of those airways, right? So you can actually have an embolus here. So this is a good point here, is that bacillin cannot be given IV because it can cause some pretty significant damage to the patient. Only going to be for IM use. It's very good when you use it appropriately, but cannot be given IV. Okay. It'd be nice if I could just give one dose of IV penicillin and they're good to go, but it just doesn't work like that. You need to have the bacillin actually in the muscle leaching out slowly, and that is how it's going to get a lot of efficacy there. Okay, so sometimes you'll find different versions of a drug that are available. You have to look back to see what the differences are, whether it's dosage form or whatever happens to be. The base it's put in can all make a difference.
Wouldn't practitioners want to use bacillin more as opposed to benzyl penicillin? And what is that reasoning for them wanting to use that IV? Because then you just give them a shot IM and and they're good to go?
Yeah, so that's a good question. So like, why would you choose to use IV penicillin versus the intramuscular? Like, you give a one-time dose of it, and you're good to go. Well, it depends on the type of infection you're dealing with. Sometimes you want to have those guaranteed higher concentrations. So for instance, sometimes you'll see penicillin being used for like an infective endocarditis, right? So if you have like a big vegetation on one of the valves, say like an IV drug dealer or a drug user, and they end up, maybe the user and dealer, I don't know, but they develop one of these vegetations there, like sometimes you really high concentrations, you want to give them very consistently. With IM, you may not always have really consistent absorption, but if I give it IV, I'm controlling it. I know exactly how much they're getting and what concentration it should be at. So typically, if a patient's coming into the hospital and they need IV therapy, they're going to get IVs, right? Because you're going to start IVs anyway. But if it's like a little kid who's coming in, they want to get them discharged and back out to go into the parks or whatever, just give them an IM shot and they're good to go. They don't have to come back to the ER multiple times for multiple IM shots or anything like that. And you do get a feel for this when you get out into practice and you learn like, okay, for peds I do this, for adults I do this, etc. But it all makes a difference, right? Okay. Excuse my phone. Up next, we have the aminopenicillin. So this is like the next, like the big brother to the original penicillins here. So the two that fall into this category you're going to deal with are going to be ampicillin, Omnipen or Principen. And again, if I don't include a brand name, it's probably because the drug is older than Moses, and we don't have a good brand name. If we do, I can't find it via Google, so just suffice it that we don't use it, and so you just call it by the generic, right? We also have amoxicillin. Amoxicillin is a very good one you're going to find used very frequently, especially for pediatric indications. Use PO only. Ampicillin can be used IV, and again, I'm not going to ask you specifically on a test which one's IV, which one's PO. However, I may ask you which route might be better for this patient based on X, Y, and Z. I may ask you, don't memorize that specific point, but I do want to at least expose you to it so you can start to see, okay, well, I know this is a good oral one. I know this is a good IV one. Because again, outpatient-wise, what do you want to use most frequently? Oral and IV, you may want to use more on the inpatient side or rather in the ER, whatever happens to be. So what you notice here is that typically with aminopenicillins, you're going to be getting a little bit better coverage. You don't have any staph coverage necessarily, right? So we're still missing staph. It's not being covered yet. Has a little bit better anaerobic activity here. It doesn't cover bacteroides, but it's a little bit better. And then we're starting to get a little bit more gram negatives here. A little bit, but not a whole ton, okay? So the drug of choice here is it actually has some specific indications where this is really good. So for things like enterococcus, it does have some good coverage against enterococcus, listeria, endocarditis. Sometimes we'll actually give this to patients who have a mechanical valve put in. And if we're worried about them getting an infection, say like after like dental procedure or something, we'll give them some amoxicillin in order to make sure they don't develop an infection, right? That's a case of prophylactic use we'll use sometimes. And then you very frequently see for a lot of URTIs, upper respiratory tract infections. So this is good coverage against strep pneumo, which is a very frequent causative agent for a lot of upper respiratory tract infections. I think otitis media, think things like bacterial pharyngitis or bacterial sinusitis, I should say. All those good things, right? You're going to find a lot of use here. And then actually in some cases, you can actually use it for community-acquired pneumonias, okay? So it has good enough coverage against things like Moraxella catarrhalis, H. influenza, strep pneumo, that this gets a lot of utility, right? It's probably one of the most frequent antibiotics we use in the ER for upper respiratory tract infections. I can tell you that for sure. Amoxicillin, very, very frequently used. And again, these are still time-dependent killers. They still have to be given pretty frequently. So in some cases, Q6 hours, 4 times a day, Q8 hours, 3 times a day, in order to make sure you stay above that MIC long enough to actually treat that infection. So some interactions to be aware of, and then kind of this goes for all the penicillins, right? In some cases you may find if a patient's on an anticoagulant, you can actually see some prolonging of those bleeding effects. So again, if you had someone who's on warfarin or something, and again, we'll cover the heme section a little bit later on in this class, but just know if they're on blood thinners, you may see some prolonging effect of that. You may see that they may be more likely to bruise and bleed, so be aware of that. The other big thing is, so who's ever heard of if you're on antibiotics, you got to use a backup form of contraception? Anyone know why that is? Remember, when we talked about, even going back to physio, we talked a little bit about enterohepatic recirculation. What is that? Yeah, so things being spit out through the biliary tract and then being reabsorbed from the GI tract afterwards, right? And again, when that happens, what do you think that does to the half-life of a substance? It increases, right? Because you're reabsorbing it and then maybe getting rid of some of it, but then you spit it back out and you reabsorb it and spit it back out and reabsorb it until it's gone, right? And so by doing that, you extend the half-life of a lot of substances. So in this case, when we're talking about oral contraceptives, what kind of 2 drugs are we talking about? Kind of broadly speaking, yeah, estrogen and a progesterone, right? So you need the estrogen there in order to make sure we're shutting down ovulation. Remember going back to LH surge and all that fun stuff, right? So you try to purge that, it'll come up again, I guarantee you. But if you go back to that, you're going to see that if I give, and again, one of the big things you'll notice with estrogen specifically is that when it gets spit out into the GI tract, it has to be metabolized by gut bacteria in order for it to be reestablished as estrogen and it can be reabsorbed. So if I give antibiotics, what does that do to gut bacteria? It disrupts them and gets rid of some of those, right? So now all of a sudden I'm not able to process and reabsorb that estrogen. Guess what? Estrogen levels will then go down, and then you run the risk of what happening? Ovulation, right? We don't want that to occur if they're on oral contraceptives, obviously, if they're using for that purpose. So it's one of those things where if you hear that, it's probably not bad advice. Now, is there clinical evidence to say that if you're on antibiotics and you're on oral contraceptives, you're going to get pregnant? That's not a very ethical study, I can guarantee you. Whoever's in the group, the more pregnancy is probably not going to appreciate that. And so there's never going to be good evidence for that. Is it good advice? Probably. Just use a backup form of contraception while you're on the antibiotics. And afterwards, you kind of get back to normal levels and you'll be good to go. But it's a good education point to your patients. And again, it's a very low risk procedure to add more contraceptives. So just go for it. And then, at least you're protecting yourself a little bit more so than not, right? Because again, is any contraception 100% effective? Abstinence is 100% effective. No. Right, yeah, nothing is going to be 100%, birth control, condoms, anything like that. So again, using a little bit of backup, probably not a bad idea. But again, you're never going to find that evidence to say, yes, this is absolutely necessary. That's the mechanism, right? You're disrupting that recycling of estrogen. Now, going into side effects, you're going to find that the penicillins in general can cause some hepatic dysfunction. It's pretty rare that you run into this being a big problem, but just be aware that it can occur. Jaundice, increase in LFTs, et cetera. With a lot of antibiotics, C. diff is going to be a risk. We're going to talk about one in particular later on, probably whenever we meet again tomorrow, I guess, where C. diff is going to be much more prevalent. However, C. diff can be a risk here. And again, this goes back to disrupting the normal gut flora. Anytime you disrupt that, you run the risk of having C. diff being an opportunistic infection, develop, and then they have that C. diff diarrhea. It's no good. So that's a risk there. Penicillins can also potentially cause things like Stevens-Johnson's and toxic epidermal necrolysis. Just know that is a severe skin manifestation you need to be aware of to educate patients on. If you see any sort of new blisters, skin sloughing off, anything like that, they need to go to the ER. Stop taking the medication immediately. Just like Professor Q was saying, if you develop, ringing in your ears when you're taking your Lasix, stop taking it. Same thing goes for this, right? So again, stop taking it immediately, go to the ER. You can also see things like, some renal dysfunction that can occur here. Things like, where the actual drug can precipitate out into the renal tubules, so things like crystal uric can occur. Again, pretty rare for the most part, and some anemias, but not common. The only things to be aware of is that if you have a patient who has a obvious and clear history of penicillin allergy, you probably don't want to give it to them, right? Don't want to cause them anaphylaxis again. And then any patients with a history of like cholestatic jaundice, hepatic dysfunction, you want to be at least more careful with, right? And we talk about contraindications. There's absolute and there's relative contraindications. What's the difference? Absolute means you should never get it. So allergy to penicillins would be absolutely contraindicated. If they have a history of liver dysfunction, be relative, which means, well, let's look at all sides, right? If the risks of giving it are less than the benefits of giving the drug, you may want to decide to do that, right? So again, relative versus absolute, good indication, or good distinctions to make in your mind. Again, with all the penicillins, and in fact, unless I say specifically that it has hepatic elimination, all the beta-lactams are going to have elimination through the kidney. So you got to watch for renal function. If you have someone who has an older patient, maybe dialysis dependent, anything like that, you got to watch them and make sure their renal function can handle the drug at the dose you're giving it to them. Otherwise, you are going to overload them. They can have more risk for having side effects, right? So sometimes you're giving a lower dose. More frequently than not, you're giving it less frequently. So maybe, for instance, I would give penicillin, say, every 6 hours. Maybe I'll give it every 12 hours, depending on the degree of their renal function, how diminished it is, right? And remember how we calculate renal function? The equation we use? Cockcroft-Gault, right? All the drug references out there use Cockcroft-Gault as their basis for that. So you just plug your patient in, see what their renal function is, or maybe your electronic medical record will tell you directly, which is very nice. Say, hey, the renal function is 40. Go in and look at the drug reference. They'll tell you specifically, hey, it's between 30 and 60, dose it like this. I mean, it makes it pretty plug and play. Not a lot of thought goes into it, which is good. Also, as far as adverse reactions go, rash can develop here. Again, they may be a little bit more photosensitive. Make sure they're covering up. They're going out in the sun. Diarrhea can be common here. And again, it goes back to disrupting that normal gut flora. So that's a very common one. And again, just monitor things like renal function, hepatic function, platelets, etc. Okay. Okay, so how do the bacteria become resistant to the beta-lactam specifically? And so one of the things you're going to find is they will develop an enzyme called beta-lactamase. So as you might imagine, beta-lactamase is going to cleave open the beta-lactam ring, and at that point the penicillin is no longer functional. So if you have a bacteria that produces beta-lactamase, it's going to basically just make all of these penicillins basically inert. They're not going to do anything, okay? So the question is, how could we overcome this resistance? Yeah, I could have a beta-lactamase inhibitors. I can give another drug on top of the original penicillin or a type of penicillin and actually cause it to be resistant to that beta-lactamase, okay? We do. So things like beta-lactamase inhibitors are going to help us with that. So we have three main ones you're going to run into. We have things like sulbactam. This is commonly given along with ampicillin to make a new brand name called Unison. You're going to have tazobactam, which is mixed with a drug we haven't talked about yet called piperacillin, which is called Zosyn. I don't know if anyone's ever heard of Zosyn before. It's a common one you run into in the hospital. And then probably everyone has probably heard of this one, but when you add clavulanic acid or clavulanate, two names for the same thing, to amoxicillin, now you have augmentin, okay? So not only does this make it so that they can overcome that resistance to the beta-lactamase enzyme that bacteria is producing, it now actually broadens out the spectrum of bacteria they can actually treat. And I'll show you an example of that in just a second. Yes, sir?
Is that considered double coverage?
That's not considered double coverage because, again, if I were to give tazobactam by itself to a patient with an infection, guess what? Wouldn't do anything. It actually does not kill the bacteria like an oral penicillin would. It just inhibits that particular enzyme. It's basically kind of like a little decoy molecule that will bind up with the beta-lactamase, will render it inert, and allow the penicillin to do its work, essentially. Okay, so yeah, not really double coverage, but again, it's a very common combination you're going to see out there of these two drugs, right? So when you add an aminopenicillin plus a beta-lactamase inhibitor, now all of a sudden you start to broaden out your spectrum. You get a lot better coverage for things. So things like anaerobes now have really good coverage. Basically everything except C. diff is going to be a good one that actually gets some coverage here, including Bacteroides Fragilis, which is something you'll see in the GI tract with some regularity. It also now starts to cover MSSA. Also good coverage, right? You know, because again, before we were looking at the immunopenicillins by themselves or just penicillin, no coverage for staph, right? Now we're starting to get some MSSA coverage here, which is good. Now you will very frequently find this being used for infections that either amoxicillin itself won't cover. So for instance, if I have someone who's coming in for acute otitis media, amoxicillin failed, I will then step up my game a little bit, go to a bigger gun, add on the clavulanic acid, give them augmentin, and that may work, right? But we also use it a lot for the anaerobic coverage as well. So if you ever have someone who comes in with an animal or a human bite, which I guess humans are animals, but any kind of bite like that, you typically think of like covering with augmentin because that anaerobic coverage is going to get all that gross stuff growing in the mouth, in addition to all the skin stuff that could be right there on the surface of the patient's skin, right? Use it for things like diabetic foot infections. You know, think about foot infections. If your foot in a shoe all day long, guess what can grow there? Not a lot of air. Well, yeah, fungus, obviously, but you can have other things like, that sounded really dismissive, I apologize. Yes, you can have fungus, absolutely. We'll talk about that later, but it's an anaerobic sort of environment, right? You're more likely to see things like anaerobic bugs can develop in that environment. Diabetic patients can tend to have those foot infections more frequently. So very good choice for all of those, right? Now, am I going to use augmentin for every skin infection I come across? Not really, because if I start to worry about things like MRSA, this isn't going to cover it, right? But if I need to worry about typical skin coverage, if I need to think about typical anaerobic coverage, so like an animal bite, or if I'm thinking about like a diabetic foot or something like that, this is a really good option for that. This is a really good set of drugs. And again, you're going to see this a lot for upper respiratory tract infections, particularly the augmentin, right, which is amoxicillin plus that clavulanic acid. Okay. Okay. Which time do I have left? None at all. All right. Any questions I can answer for you before I go? Yes, sir.
Can you explain why is it that we can't reabsorb the estrogen and progesterone again?
Yeah, so in particular, it's the estrogen we're dealing with. Basically, when you disrupt the gut flora, you need those bacteria to basically kind of munch on the estrogen, because normally before it gets secreted out, it gets conjugated with something else, like maybe like a glycine or glutathione or something like that in the liver, and it gets spit out. The bacteria will then cleave that, reproduce the parent estrogen, like estradiol in this case, and then you would reabsorb that. If you disrupt that, you just have the conjugated form that just gets spit out.
Bacteria that
basically do the recycling, right? So it's going to recycle the estrogen and allow us to reabsorb it. Okay. Because again, the liver spitting things out to the biliary tract is making it more soluble, so that way it'll go through the feces instead of being reabsorbed in the first place. So you need those bacteria there. Any other questions? All right, I will see you guys tomorrow. See you later.